My name is Deborah Miller. I'm the Director of Health Policy at the CSG National Headquarters in Lexington, Kentucky. You've joined us today for a webinar to update and provide information. We've titled it The Latest on Federal Medicaid Waivers. We have two speakers today, one of whom comes directly from a state and will tell us about the Indiana waiver, and then a second speaker who will do sort of a national context and overview. I need to do a couple of housekeeping things. I think you've already received a message, but you are in a listen-only mode if you've joined us for the webinar. You can type in questions in the GoToMeeting box that you should see on your screen at any time, and we get to those questions as we can. We ask them here from our Lexington office to the speakers. The audio and slides will be posted on our CSG Knowledge Center following this broadcast, and we encourage you to use them for your resource and to direct your colleagues to them. And you'll also, as an attendee of this webinar, get a notice of the link to those slides and the audio. So that's kind of the housekeeping piece. Our first speaker today is Representative Ed Clear from Indiana. In Indiana, he is the chair of the House Public Health Committee, and he is co-chair of CSG's Health Policy Committee for 15 and 16. He stepped away from the House floor today, they are in session, to join us and to tell us about the new Indiana waiver for Medicaid expansion. It was long under review by the federal government, finally approved in January of this year, and implemented beginning February 1st. Indiana's is the most recently approved waiver and is probably the most different waiver approved to date. Representative Clear will not be able to stay with us for the entire webinar, so if you have questions of him as he's speaking, if questions come up, please feel free to go ahead and enter them in that GoToMeeting box, and as he can share his time with us, we'll try to persuade him to take a few of those questions. So I'm going to turn it over to Representative Clear now. Thank you.
All right. Well, thank you, Deborah. Great to be on the call today, and I'm excited to be able to talk about what's happened in Indiana. It was under review for quite a while. Governor Pence first announced the HIP 2.0 program, the application for it last year, mid-year, and it took a while to get approval, but I think we're glad the process worked the way it did, and we've arrived at a good place for not only the several 100,000 Hoosiers who will receive coverage as a result of HIP 2.0, but also for the entire state. One of the things that I like to talk about is the role of Medicaid expansion in terms of Indiana's overall health status, and unfortunately Indiana ranks 41st in the country according to one prominent health study or survey, and I think this is a big part of improving our ranking. HIP 2.0 is a program that it's an 1115 waiver, and we're building on an existing waiver program, HIP, the Healthy Indiana Plan, that the General Assembly first passed in 2007. It was a bipartisan initiative. That was before I was in the legislature. I was elected in 2008. So in 2007, bipartisan bill created HIP, and it was a very successful program, although it was limited in enrollment. And we ultimately got up to, toward the end of the original HIP program, I think about 60,000 people enrolled, but more typical enrollment was probably around 40,000 or fewer. and it was supported by cigarette tax money. So that was one of the reasons for the cap on enrollment, was the availability of funding. And it is the original HIP program and now HIP 2.0 that was built on it follow a consumer-driven approach to healthcare. Each participant has a power account, which is a sort of health savings account. It's not a qualified HSA as far as the IRS is concerned, but it's an account that tries to teach folks about making decisions regarding their own healthcare spending. And we've had a high level of satisfaction throughout the original, the 6 or 7 years of the original HIP program. The new HIP program, HIP 2.0, has a HIP Basic and a HIP Plus, and the HIP Plus requires more responsibility from the individual participant in terms of making contributions to the power account, and in return they receive enhanced benefits including dental and vision. So our Medicaid expansion population is up to about 400,000 people, and enrollment has been brisk, and I expect will continue to be brisk, and we're excited that we received approval, and looking forward to what it means for access to health care in Indiana. So Deb, I don't know if I covered all the basics, but I'm happy to answer questions and stay on the phone here as long as I can.
Can you tell us a little, Ed, about what the role of the legislature was in creating that HIP 2.0 application?
Mm-hmm. Yeah, the legislature took a pretty hands-off approach, pretty much left this up to the governor, and Governor Pence made it clear that he was not interested in expanding traditional Medicaid. He was only interested in expansion of coverage that was based on the HIP program and the principles that it represented, the original HIP program, that is. So several years ago, the legislature gave the governor broader authority to modify the HIP program, basically to use the HIP program as a vehicle for Medicaid expansion, and that's what the governor did. But the legislature did not have any direct involvement in creating HIP 2.0.
Have you had to do any appropriation yet or anything like that through the legislative branch?
No, I think we'll probably have some fairly technical language that cleans up a few things this session. But I'm glad you asked the question, Deb. The way we came to agreement, or the way Indiana came up with this program from a fiscal standpoint, was based on the hospital assessment fee, and the administration worked in partnership with our hospital association, which was a leading advocate, probably the leading advocate for coverage expansion on the provider side, and the hospital association and its members agreed to an increase in the hospital assessment fee as a way of providing for expansion without any cost to the state. So you know, we're still in the 100% match period, federal match period, but as that decreases, the hospital assessment fee will fill that gap.
So physically, this is expected to be neutral for the Indiana state budget.
Yes. Now, I'm not sure, you know, I guess the only asterisk is on the administrative side. I know on the state match side, we're obviously counting on the hospital assessment fee, and I think the administrative costs have been factored into that as well. But certainly the perception or the understanding is that there is no fiscal impact on the state, or a very minimal fiscal impact in the short term, and the structure with the hospital assessment fee is intended to minimize any impact on the state budget going forward.
Okay. I do not believe we have any burning questions. I'm sure that our participants on the webinar understand that you need to get back to the House floor, so we certainly appreciate your overview of the Indiana program. When we post this, I'll be sure and include some links to some of the official documentation, so that if people are interested in seeing more about the waiver program, they can do that.
Sure. Yeah, I appreciate that, and if anyone has any questions later, I'd be happy to follow up individually with folks. It's an interesting pathway, to say the least, how we got here, but many of us are very glad that Indiana was able to find a way forward, and looking forward to the positive implications for the state, again, not just to the hundreds of thousands of folks who may receive coverage, but also to the entire state. And we'll have to see how things play out with respect to the two-tier program, the HIP and HIP Plus, and the various elements of that. I think we'll learn a lot over the next year or two, but in the meantime, many of us are just glad that Indiana is able to take advantage of coverage expansion. So I hate to jump off the call, but I appreciate your understanding, and appreciate everyone who is listening and interested in this topic. And again, I'm happy to have any kind of individual follow-up that would be useful.
Okay. Thank you very much. Thank you.
All right. Thank you. Take care.
Thank you. Our next speaker on the call will be Jesse Cross-Call. He's a policy analyst with the DC-based Center on Budget and Policy, the Center on Budget and Policy Priorities. He works in the Health Policy Division of the Center, where he examines issues and writes analysis related to health reform. He also provides technical assistance to state and local officials and others related to Medicaid expansion. Jesse understands and, in fact, has lived the state policy perspective, as he served as Chief of Staff to Alaska's Senate Majority Leader before moving to Washington, D.C. to work at the Center on Budget and Policy Priorities. Jesse has presented at our CSG Medicaid Policy Academies before, and I know that you'll enjoy hearing from him. He's going to give us a national overview of Medicaid expansion and the waivers.
Great. Thank you so much for that introduction, Deb. And hi, everybody. Thanks for joining this webinar today. And just as a little bit more background, for those of you who may not be familiar with the Center on Budget and Policy Priorities, we are a think tank in Washington, D.C., and we have a specific focus on programs that affect low-income populations. And so for my work on the health team, we do a lot of work around Medicaid and the Affordable Care Act and the different provisions of the ACA. And I really do enjoy these opportunities to speak with state policymakers and staff because, as Deb mentioned, that is my background, and I still very much follow what goes on in states. So what I'm going to do this afternoon is I'm going to take a walk through where we are with Medicaid expansions around the country. I'm going to start out by talking a little bit just around the impact that the expansion has had so far in states, but really the bulk of the time I'm going to devote to where the debate is now, especially in the policy arena, because there are, in the middle of state legislative sessions, this is a very hot topic in a number of states. So next slide, please, Carrie. So here's where we are right now. This is the Medicaid expansion state of play. As you can see, that there are 28 states plus the District of Columbia that have expanded at this moment, and 22 states that have not. This map has changed a little bit since the expansion took effect in 2014. We had New Hampshire expand on July 1st. Pennsylvania came on board on January 1st. And then Indiana, as Representative Clear was just walking through, came on board on February 1st. Next slide, please. And also to lay the groundwork for everything, just wanted to take a look at where Medicaid and CHIP eligibility levels are right now. And you can see that as you are no doubt aware, the Medicaid expansion is a targeted expansion of Medicaid eligibility, primarily for adults, parents, and childless adults. And you can see across states, so this is the medium Medicaid and CHIP eligibility levels right now. So this means in the typical state, as we say. You can see that for children, Medicaid and CHIP coverage is up to 255% of the poverty line. Pregnant women, 205%. But I really want to focus on the next two categories of parents and childless adults. So you can see that for these two categories in the states that have expanded, their eligibility is now, as the Affordable Care Act envisioned, up to 138% of the poverty line. And that works out to about $15,000 a year for an individual. But there is a split, because in the states that have not expanded, there is no coverage for childless adults at this point. And there's limited coverage up to about 45% of the poverty line for parents. And so this is sort of the first split that we see between states that have expanded and those that have not, just in the eligibility levels. So what impact has that had so far? Next slide, please. So we are slowly learning about how the expansion is impacting states. We're a little over a year in, and data is coming through on a continuing basis, but there are some things that we can say at this point. The first is that the uninsurance rate is sharply down in expansion states. I would mention that across the country, the insurance rate, or the uninsurance rate, excuse me, has gone down since the ACA took effect in 2014, but it's most pronounced, those gains in insurance coverage, in the expansion states. The second is that and this is what we noticed really in the first quarter of last year, and the trend has continued, that hospitals are seeing, in expansion states, are seeing many fewer uninsured patients coming through the door, sometimes to the tune of nearly a 50% drop in the admissions of uninsured patients. And I think that this is a huge reason that we've seen hospitals advocating for expansion around the country. Representative Clear mentioned that they were a huge driver to get Indiana to expand, and we've seen them playing a very prominent role in states like Florida, Kansas, Tennessee, that are debating whether to expand at this moment. And then also, because the expansion for the first few years is 100% federally funded, we have seen in the states that have expanded that their state Medicaid spending has actually been growing at a slower rate than non-expansion states. So again, that's just the amount of state money that states are putting toward the expansion. Next slide, please. So that's kind of background on all this, but I really, sort of the bulk of the presentation today, wanted to talk about where the expansion debate is in states right now, in those 22 states that have expanded. And the discussion really is very different now than it was in 2013. 2013 was the first year, or the first round of legislative sessions after the Supreme Court decision, where states had to decide whether or not to expand Medicaid. At that time, the whole first batch of states that came in just did it through a state plan amendment. They just raised their Medicaid eligibility levels. But starting with the Arkansas waiver in early 2014, the discussion really changed. And as I always say, that the discussion right now is about as much how to expand Medicaid in the state as it is about whether to expand. So in many states right now, and all of you on the call today are probably very aware of this, you have these two conversations happening side by side. Should we expand? And if we do, how should we expand? So I wanted to provide, before we jump into what some of these waivers look like, just wanted to provide a little bit of context for what we are talking about when we are talking about a Medicaid waiver. So prior to health reform, waivers were used quite often. These were called Section 1115 waivers. And they were the primary vehicle that states used to extend coverage to groups who were not otherwise eligible for Medicaid. And these were often how states could extend coverage, often in a limited way, to childless adults. A couple features the waivers had to meet. They had to be budget neutral to the federal government. And so that means that if a state wanted to cover more people under its Medicaid program and expand eligibility levels, it had to find offsetting savings elsewhere in its budget. States did this in some instances by using managed care more often, using those savings to fund the coverage expansions. Representative Clear mentioned that in Indiana, they actually raised money or raised revenue through the cigarette tax to fund their expansion prior to health reform. Now, the ACA changed all this because it set up this explicit pathway to coverage for childless adults. So rather than states having to nibble around the edges to find ways to do incremental expansions of coverage for adults, the ACA created this explicit pathway to coverage for adults. And even though the Supreme Court, in their decision in 2012, made the Medicaid expansion an option for states, it didn't change the fact that this pathway to coverage exists. And this is a really important point as we get into what waivers can look like and how far they can go. Next slide, please. So as I said, the first batch of states that came through just did a state plan amendment and just simply raised their eligibility levels and made the expansion population eligible for Medicaid. Early on, sort of in the run-up to 2014 legislative sessions, HHS signaled that it'd be open to waivers for expansion. The first state that really took them up on this offer, you could say, was Arkansas. And Arkansas has gotten a lot of ink, rightfully, I think, for its expansion of Medicaid. They were the first to do so, and they're really a trailblazer in the Medicaid expansion debate and the Medicaid waiver debates. And around the time that Arkansas first floated their idea for their waiver, HHS put some really important ground rules in place for the expansion waivers. The first one is that states cannot use a waiver to do a partial expansion. That is, the state can't only go up to 100% of the poverty line and get the enhanced match. For example, Wisconsin did only expand to 100% of the poverty line, but HHS said that they had to get their regular FMAP if they did that. And HHS has held the line on this. So any state that contemplates expanding Medicaid in a way so that they can get that enhanced FMAP where the match is 100% for the first few years, they have to do it up to 138% of the poverty line. Now, for the second one is very specific to Arkansas, because as you may know, Arkansas, as part of their waiver, the expansion population is that the state uses the Medicaid dollars to buy a private plan for the beneficiaries on the health exchange. And the HHS said that if you go this route, if you enroll your Medicaid population into a qualified health plan in the exchange, these beneficiaries remain Medicaid beneficiaries. So that means that the state had to wrap around certain benefits that come with being a Medicaid beneficiary, and cost-sharing rules applied And so they made sure that states understood that, again, we are still dealing with Medicaid beneficiaries here. And then the third one is also, I think, an important point. And the HHS reiterated that any waiver has to have a clear demonstration purpose. Waivers are really, the technical term for them are demonstration projects. And what states, and this goes back again to before health reform, states have to be demonstrating something. They have to be finding out how the program that they're setting up expands access to care or impacts beneficiaries' behavior. And so there has to be an articulated demonstration purpose. Next slide, please. So again, Arkansas was the first state to come, and they came in February 2013. And really, that's the Arkansas waiver changed the ballgame. And it really made the discussion of Medicaid expansion a discussion about waivers. And what we have seen is that post-Arkansas and continuing to this day, states that are really looking to put their stamp on expansion. And you can just tell this by the way that the names that they're giving to their programs. So, the approved demonstration projects, it's the Arkansas private option, it's the Healthy Michigan plan, Healthy Indiana plan, the New Hampshire Health Protection Program, Healthy Utah. So the states are not talking about adopting Medicaid expansion, they're talking about whether to pass Healthy Utah or Insured Tennessee. And that's just a flavor, or I think that that's just indicative that states are really looking to put their own stamp on the Medicaid expansion. Next slide, please. I'm not going to dwell too much on this slide, which we have borrowed from the Kaiser Family Foundation, because I'm actually going to run through a lot of these different policy areas right now. I think this will be useful if you actually wanted to access these slides later on in review. But this just goes through side by side some of the waivers. The one that is actually missing because it was approved last week is New Hampshire. But this looks at some of their different policy options that HHS has granted approval for. And I would also say that if you are ever curious about what a specific state is doing in its waiver, the Kaiser Family Foundation has put together really well done fact sheets on each state that has secured a waiver. If you just Google Kaiser Family Foundation Arkansas waiver, you will find their fact sheet, and I refer to those fact sheets all the time when I need to remind myself about what's in each state's waiver. So let's do a deeper dive around some of the policy options or the different policy considerations for states. Next slide, please. So as I said, every state is doing things a little bit differently. No state is just doing exactly what Arkansas is doing or exactly what Michigan is doing. They're each trying to put their own stamp on things. And as we followed this at the Center on Budget, we've noticed that there have been some guardrails that HHS has expanded, or that HHS has established over time. They've not let states do absolutely everything that they've wanted, but they have given states significant flexibility that was not accorded to the states that just went through a state plan amendment. And so we've started calling these expansion guardrails. The first one is around premiums. So this first guardrail just says that people below the poverty line cannot be disenrolled for non-payment of premiums. HHS has allowed premiums for the states that have expanded via a waiver. But they've made a really important distinction between people who are above the poverty line and below the poverty line. For the people below the poverty line in some states, Indiana being an example, you can be disenrolled from coverage after a grace period if you miss some of your premium payments. There are two states, Indiana and Iowa, that have been allowed to charge small premiums to people below the poverty line. But HHS has made it very clear that you cannot disenroll individuals from coverage if they are unable to pay their premium. So the second area that states have kicked the tires on is around cost sharing. And I'll just mention here that there's pretty significant flexibility within the Medicaid statute around cost sharing that can be charged to people. For example, states can vary the amount of cost sharing by income, and charge people, or people with higher incomes can have a greater cost sharing obligation than people with lower incomes. And then there's very important protections around cost sharing for people below poverty. This is an area that states have kind of stayed away from because they understand that they have this flexibility already, and these are cost sharing as a way that they can pursue some cost sharing provisions outside of the waiver process. And then the next one is just around the benefit package that the expansion population can access. So Iowa was one state that tried to waive EPSDT for 19 and 20-year-olds. HHS denied this. States have also kicked the tires on waiving non-emergency medical transportation. And they've actually given one-year waivers to Indiana and Iowa to see what the impact that would have on access to care if the non-emergency transportation benefit were waived for a year. So that's an issue that we're going to be following very closely to see what the data says about whether having that benefit waived impacted the ability of beneficiaries to access care. And the data is not in yet, so we'll be very interested to see what it says. Next slide, please. Now this fourth item is really, it's been a hot topic in states. I think it's probably cooled down a little bit, but it does keep popping up. And this is states are trying to tie eligibility for Medicaid coverage to whether a person is working or engaged in a work search activity. It's important, HHS has made it very clear that Medicaid is a health care program and its purpose is to extend health care to individuals. It's not a work search, it's not a driver to get people to work. And so, again, Pennsylvania pursued a provision that would require anybody who is working less than 20 hours a week to engage in work search activities or have their health care taken away from them. HHS denied this and said, no, you can't do this. But some states are very gung-ho about this idea, and so two in particular, New Hampshire and Indiana, have kind of found a way to work around it. And what they've set up is a system where when people apply for Medicaid coverage and gain coverage, they can be referred to a state-run job search program. So Medicaid eligibility, their eligibility is not conditioned on participating in that program, but they do, as part of their coverage, get referred to this job search program that they can enroll in. And then the fifth one gets a little fuzzy. So Medicaid expansion waivers have varying lengths to them. They are not set up for an indefinite period of time. From the beginning, and again, Arkansas was the first state to go, and they had the premium assistant waiver. HHS said that those waivers are available for up to 3 years. Other states, like Michigan, for example, which is not using premium assistance, has a 5-year waiver. But Arkansas, Iowa, and New Hampshire are the 3 states that are using some form of premium assistance. They have their program will last for 3 years. That doesn't mean that it ends after 3 years, but after 3 years, the state can renew the waiver, but they have to, there's an evaluation component to all these waivers. The states have to do an evaluation to see if they met the objectives that they set out at the beginning, and HHS will decide at that time whether to renew the waivers. So again, there's varying lengths of the waivers, 5 years, 3 years, but if you're using premium assistance, it can only extend for 3 years. Next slide, please. And so this is a slide that I think is just an important consideration for any policymaker, and I also think for HHS as well. And this is just to think if these waivers perhaps are getting very complex. I mentioned the fact sheets that the Kaiser Family Foundation puts out around each waiver. And even though it seemed complex at the time, now the Arkansas waiver looks very simple. It's the fact sheet that Kaiser put out for them is just 2 pages front and back about how their Medicaid waiver works. Indiana, which is the most recent state to get its waiver approved, is 8 pages. And states are setting up these ever more elaborate systems for the expansion population to gain care. And I think that there is a question about whether these waivers are making it harder for people to enroll in coverage, to maintain their coverage. But I think it also places a burden on the states to administer all these provisions. The states have to figure out how to administer the HSA-like accounts that Indiana is setting up, and Michigan as well. States have to track people's premium payments across their income levels. And we're seeing already that some states have got a little bit of cold feet around this. So, for example, Arkansas, they thought about imposing accounts in the 2nd year, but they actually scrapped this idea because they realized that the state was going to have to spend a lot of money to administer those accounts. And then Pennsylvania actually had a waiver that was approved by HHS. I have not mentioned it because when they got a new governor this year, that governor scrapped their waiver and just went with a straight expansion because he thought it would be just easier for the state to administer and easier for beneficiaries to enroll and to maintain coverage. So with that, that is the presentation I have. I'm happy to answer any questions that you may have about specific states. Perhaps you'll ask me to read the tea leaves about where HHS is going on this. I'll try my best to do that. Just do my best to answer any questions you may have. So thank you.
Okay, a few questions, Jesse. Tell us a little, I know there's been some action. This is Deb Miller. I follow some of that action as well. And so there's been some work in some action, I guess, in Tennessee, Wyoming, who else? At least those 2 states.
So are you asking the update about where things are?
Yeah, where are those states? I think they were, at least Tennessee was mentioned in one of your slides as being in play.
Yeah, so Tennessee was a very notable example because their governor, Bill Haslam, came out with his own plan kind of in the way that Governor Pence did in Indiana, where the governor came forward and said, here's a plan. And he did this in December, and he called a special session at the beginning of February for the legislature to consider his expansion plan. It got a lot of attention, rightfully so, because Tennessee is a big state. It's in the South, and there are really just a handful of states in the South that have expanded. And the Tennessee proposal was pushed by hospitals. And like in Indiana, the hospitals said that they would fund the state's share of the expansion through a provider tax, again, in the way that Indiana hospitals did. And it, as a Republican governor putting this proposal forward, it looked like there was a good chance that it would pass. But once they got to the special session, it was clear that the governor didn't really do his homework to get legislators on board, and they voted down his proposal. So Tennessee, they're in their regular session right now, and they will be for the next few months. So there is the chance that Insure Tennessee could come up again. But because it failed in its special session, the odds are much longer for Tennessee. And there are a handful of states that are still contemplating whether to expand right now, and so Utah is very hot right now. I think that their legislature gaffles out perhaps even at the end of this week. Alaska, Florida is giving some renewed consideration to expansion. Montana and it looks like Wyoming's not going to act this year, but it does seem that there's a lot of tension really in the Mountain West. around expansion, and we're going to know pretty soon because a number of those states will be gaveling out in just the next few weeks.
Okay. Is there any connection of the expansion questions and waivers with the case that's before the Supreme Court right now?
You know what, we are definitely hearing that from some legislators in states. We've seen some legislators, and I'm thinking specifically about North Carolina at this point, where they've said, we want to wait till after the King case gets decided to determine whether to expand Medicaid. The King case is not deciding Medicaid dollars. It's deciding whether federal subsidies can flow in the federal exchange states. But, for whatever reason that those policymakers have for using that as a rationale, that is certainly popping up in a state or two.
Okay, we're starting to get some questions coming in. What is the best source for data regarding the fiscal impacts to states which have done the traditional expansion?
I wish that I had a data set that just, looked across all states and gave us the answer, but that probably won't exist for some time. We do know, I guess that's a way of saying that we don't have an authoritative look at all 50 states and what the fiscal impact is going to be. But I will make two notes. One, there are states that have come forward who have expanded and very clearly demonstrated that some of the projected savings that they thought they were going to get have materialized. So for example, one of the wildly successful expansions happened in Kentucky, where the governor released a report that I think was done by Deloitte Consulting, where they just went through and demonstrated not only the gains in coverage that have happened in Kentucky, which have been very dramatic, but also, again, that the state has saved money. That it's also happened in Arkansas, again, very successful expansion there, and in Michigan and in New Mexico. And these savings are coming from the places that they were projected to. This is, the states are spending less on their own uncompensated care funds for hospitals. They're spending less on mental health programs. They're spending less on health programs outside of Medicaid that serve low-income populations. So we are certainly seeing that from states.
Okay, and a second data question is, related around outcomes, health outcomes, and is there any data yet which looks at states' health outcome data, both who expanded traditionally or did the waiver, and I guess you could also contrast it with those states who've done neither.
Yeah. You know what, Deb, I have a notion that some of those initial, for some populations exist, but I don't have it at my fingertips. That's something that I can check on, and if you're going to be able to distribute some materials afterward, I'll see if I can dig something up this afternoon and pass them along. Again, it's very early. A year or 14 months it's a long time, but it's sort of in measuring outcomes. It's not a huge amount of time.
Yeah, I think it's always interesting when we do data work around health outcomes, and the Centers for Disease Control and Prevention are sort of the gurus of data and the authoritative places to go. And it's calendar 2015, and we're still looking at 2012 data.
Yep.
Even the uninsurance data that we have, to my knowledge, at this point, most people are using that Gallup HealthWays data because the census data hasn't yet caught up with Medicaid expansion. The latest data out on adults and insurance rates is pre-expansion.
That's right. Yeah, the census data is still from 2013.
Yeah, so it takes a while for data to catch up with what's going on at the ground level.
Yeah, and look, I very much appreciate that if you're in a state where you're making a decision whether to expand or not, you want data, you want outcomes, you want something to rest or to hang your hat on. And like I said, that just doesn't exist right now. But the evidence so far that we've seen sort of in a case-by-case basis is positive.
Yeah, I've looked at the Deloitte report done in Kentucky since we're headquartered here in Kentucky, and one of the pieces of data that they looked at that's not health outcome or fiscal data, but they were able to look at some job creation data in the health field and even outside of the health field, and that would be a place that people might want to look as well. The other question that's come in is any thoughts, Jesse, on Arkansas and the relook they're taking on their expansion plan, on their current waiver? Or just for one, tell us what's going on, and for those who may not know.
Yeah, what I think that this question is going to is, Governor Mike Beebe, who was the initial driver to get the premium assistance private option expanded in Arkansas, he got term limited out, so he's no longer the governor anymore. And the new governor, Asa Hutchinson, he came out, supported continuing the private option for the next few years, but they're actually going to sunset it after a few years because they're going to kick the tires on something called state innovation waivers, which, believe me, are the topic for its own webinar. So, that's another hour of time that would be needed to really go through state innovation waivers. But essentially what state innovation waivers allow, and this is part of the Affordable Care Act, is that they allow, starting in 2017, for states to do a combined waiver application where they can look at the coverage landscape in total, not just Medicaid, but also the money coming into a state through the premium tax credits and the exchanges, and create a new system for covering people. There's very important rules around these waivers that you have to, like, for example, states have to cover just as many people with the waiver as they did now. They have to have protections for the beneficiaries on the benefits that they get, on their out-of-pocket costs. So there's some very important protections around it. It doesn't allow states to just do whatever they want and take the federal money and sort of go willy-nilly, but it does allow states to think differently. And again, they don't take effect till 2017. So a very small number of states, of which Arkansas is one, are starting to think about whether they should pursue these state innovation waivers. And again, they're a new thing, so there's not, there's really the statute and some research, including some that's been done here at the Center on Budgets, that has looked at these waivers, but they're a new thing. And I think that to the question about Arkansas, I think that that's what the questioner was getting to, that the private option is in place for the next few years, but the state is going to look into whether they want to cover this population in a slightly different way. And that work really hasn't begun yet.
And yet another data kind of question. This question is, what specifically has been seen as something that has been proven, or what has been proven, to reduce costs, or as we call it, bend the cost curve for Medicaid in expansion states? Or more generically, you could talk about what are some of the ACA pieces that look at bending the cost curve, whether you're expanding or not. And again, I would say, it may be too soon to have data on that, but tell us about a couple of the big initiatives around cost containment or bending the cost curve. I'm thinking of things like patient-centered medical homes.
Yeah, so it's both sort of in where patients get care, and so the medical homes and affordable care organizations, and then even some states are just, who haven't made the move to manage care yet, are contemplating doing so through their waiver. And so that these are, managed care, which has been around for quite some time, obviously, has been, in instances shown to reduce overall costs, and so states are contemplating using the expansion as an opportunity to pursue that. And then there are other, within the Medicaid statutes, other options available to people, or sorry, to states, such as patient-centered medical homes. That's a very good example. And we are actually preparing a paper here that I think is still a few weeks away from being published on some of these areas that states can pursue to to get savings in their Medicaid programs while not cutting people off of care, basically. And then also, it's just been, for example, in the Kentucky report, it does expanding healthcare to people increases a population's health, and we're starting to see that in the expansion states. And this is one of the reasons that the federal match was set up the way that it was, with 100% match in the first three years, for the federal government to cover the cost when people first come in and when they're most expensive, when they might have some conditions that have not been treated for some time because the person did not have access to care. And then the idea was that as they have and maintain their health insurance through Medicaid, their costs will come down over time as they're not waiting for months to see a doctor, as they're getting conditions treated on the front end.
Can we expect, I'm just sitting here in my brain thinking, can we expect at the end of the 3 years in Arkansas, because they did the premium assistance, some comparison of their costs under premium assistance to quote-unquote traditional Medicaid, so that might be some kind of a, sort of a study of which way saved money? Is that what that evaluation would look like?
Right. So like I said, there's an evaluation component to every waiver, and that budget neutrality component is going to be a big thing in Arkansas. Just as a brief aside about how Arkansas was set up, as I said, waivers have to be budget neutral for the federal government. Arkansas, again, was able to use federal dollars to purchase private plans on the exchange that's set up by health reform. And part of the reason, or part of the way that they calculated that this would be budget neutral, was that their traditional Medicaid program had very thin provider networks, and really there were some troubles just with access within their Medicaid program. And so they did some calculations where they said, okay, if we expanded in the regular routes and we had 200,000 people join our Medicaid program, we would have to spend a lot of money further developing our provider networks, because as they exist, they would not be able to handle the demand. And so the budget neutrality calculations in Arkansas took into account what the state would have to do to beef up its provider networks without premium assistance. And so the comparison in Arkansas is not going to be between the premium assistance and the regular Medicaid program. It's going to be between premium assistance and a regular Medicaid program that would have had to have been reformed to allow for greater access.
Okay. And so those kinds of pieces we won't be seeing if there's a three-year implementation and then a study period, or at least a period to release data. We're probably 2 to 3 years away from seeing that kind of data. Would you guess?
Yeah, and but I also think that this isn't a reason to not expand. I don't think you're ever going to have the perfect answer that's going to tell you yes or no. There are factors that I think states should be aware of that really should compel them to expand sooner rather than later. One, as I've mentioned, is the enhanced match, which is always a good deal, but it's an especially good deal in 2014, 15, and 16, where the feds are paying 100% of the cost. And It's going to go down over time to 90%, but in the first few years, again, the intent was to get people in the door. If they had some untreated conditions, to get them treated with the feds paying the bill in those first few years. And I think that's a reason that states should expand now, but also making the decision to expand, the states can back out. And some states have explicitly sunset their expansions after the first 3 years so they can reevaluate. But a state could expand just for 2015, 16, and 17 and reevaluate after that point. But waiting until 2017 when you may or may not get this really good report out of one state, I think you're sacrificing a lot.
Okay. I think do we have one more question coming in? Let's see. Oh, and it says, what states have waivers that are similar to each other for comparison purposes among states? And specifically interested in New Mexico, although I don't believe New Mexico has one yet for, so I guess,
right.
Again, it's the date, it's what's out there for people to look at to see what states have what and to compare.
Yeah, so New Mexico does not have a waiver. There are no two states that have like the same waiver. There are states that have very similar components to each other. So, like I said, Arkansas is covering its entire expansion population through premium assistance. In Iowa, they're just doing it for people between 100 and 138% of the poverty line. Again, Iowa and Indiana have been allowed to charge premiums to people below the poverty line, but the premiums are set up differently in each two states. So even there, it's not a perfect comparison. The Kaiser Family Foundation, again, has put together some good tables where you can compare states side by side, and this is included in my slide deck. And you'll see that there are some themes that run throughout states, but there aren't perfect side by sides. And that's and again, that's like I said, states are putting their own stamp on expansion. Each state wants to do things a little bit differently than the other.
All right. Well, that's the end of our questions. It's also the end of our time. And I want to thank Jesse and, of course, Representative Claire, who's probably already cast a couple of votes on the floor of the Indiana House by now, for your participation, Jesse. And your contact information is both on the screen and will be available in the recorded information on the CSG Knowledge Center. So you may be hearing from some of our folks who participated. And we thank everyone for attending. As always, we always ask at CSG that you let us know what other kinds of topics and speakers you would be interested in. You can reach me through email, dmiller@csg.org. It's one of those pretty obvious email addresses in this age. And let us know what you're interested in, and we'll try and put together a webinar for that. We're interested in meeting our members' needs. So thank you very much for tuning in today.